Good afternoon.
Good afternoon.
Good afternoon.
There was too much of a pregnant silence.
I'm trying to remember what the date was. It's February 6th, it's Friday, and we are here with the Joint Fiscal Committee. A bit unusual for us to meet during the while the legislature is in session. However, we have an important cooperative agreement to review and possibly approve, JFO number 3272. But before that, I'm going to call us to order, and we need to approve the minutes from November 13th.
So moved.
Thank you. Representative Shai moves that we approve the minutes. Is there any discussion? Seeing none. All those in favor of approving the minutes of November 13th, please say aye.
Aye.
Those approved? Opposed? And it is unanimous with one absence.
And
Oh, and an abstention.
One abstention, I was
One
not here.
abstention. Yes, thank you. Very responsible. And with that, I think we will get to the main purpose of our meeting, which is to take a look at the grant. We are going to start with Nolan Langwell and Ben Harvey from Joint Fiscal Office and Legislative Council to just present some framing for our work today.
Good afternoon. For the record, Jennifer Carby, Office of Legislative Counsel.
Nolan Langwell, the Joint Fiscal Office.
Yes,
The microphone is designed so that
Yeah,
we can
it's
hear
really
you. I
close.
wonder if you turned on. Just leave it close. Thank you. Great. There's a lot of white noise in this room. So.
That's right behind you.
yes. All right, so you're going to be hearing next from the Agency of Food Services about the Rural Health Transformation Program grant that they've received. And we are still working and we'll be working with you to fully understand what's in it and what's the budget as it moves forward. But to start off with, we just wanted to go over a couple of overarching issues and themes that I think you'll hear should keep in mind as you hear from them. First is that this is the first of 5 one-year grants, assuming there are no federal changes and the federal government remains happy with our implementation. Yep.
Back camera alert. Okay.
Yeah.
Okay, great. Sorry, continue.
Okay.
You might actually have to move that like really closer to you. Sorry.
That's good.
Thank you. So there were the grant calls for, or the program calls for 5 one-year grants, and they'll talk to you about what that means. But there are a lot of federal parameters set for what the money can be used for, and it will be very closely monitored by the federal government and enforced by the federal government. Very strict parameters if you've looked at the packet. There is a lot of federal reporting that is required as part of implementation of this grant. And as we understand it, and again, you'll hear more from the AHS folks, but there is really little to no room for legislative policy making at this moment. The timing is very tight to spend this money in the period of time that we have it for.
And to even get this far, I just want to remind folks that it was a very, very short timeline for the administration to actually fill out their grant. And then we had a good call with NCSL yesterday, and they gave us some good background. But one of the things I found most interesting was that they talked about there's 3 gates that they needed to go through in the process for official approval. One was to actually get the award approval. That's where we were. And that second was the approved budget. Once you get approval, you have to resubmit the budget. They did that last week. I think there's a copy of the most recent version. I've been informed that will probably change and then change and then change again, but you have the most up-to-date. But once we get the approved budget, then once that budget is approved, there's still restrictions of the funding. You still have to get the funding unrestricted. So there's a lot of hoops that have to go through to get to that point. I think that's it.
So I think that's it for us for the introduction, but there's a lot of good information that you'll hear from the AHS folks. And as we said, a lot of work that was done very quickly in order to have Vermont qualify for this money.
Let me know if this isn't for you, thank you, or whether I should wait. But I understand that this is called a cooperative agreement rather than a grant. And I I'm not sure I understand what the difference is and what that.
We're going to defer to the administration on that one.
Fine, thank you.
Thank you both. Really appreciate it. Thanks for all the work we're gonna do on future with this.
Yes.
I'll thank you for that too, Jill. If you two would like to join us.
That's slides. Am I being mic'd? Is it working? No.
Get it really close. to you.
Really close, how's that?
Yeah.
Okay, I have a loud voice, so I always find the mic disconcerting because I fear missing you. So if that's happening, just go like this.
We'll be okay.
Okay. I'm Jill Olson. I am the Vermont Medicaid and Health Systems Director. So I serve under the Secretary in the Secretary's office, and I have broad responsibility for the Medicaid program across the agency and healthcare reform. I'm new in my role. I've been there at the agency full-time since the middle of October. So I kind of came in as we were doing this work.
Yes. Good afternoon. I'm Tracy O'Connell. I'm the Chief Financial Officer for the Agency of Human Services and assisted with the team in developing this grant award.
Thank you. So we do have some slides to go through, and I think Tracy's going to be the driver, which I really appreciate. I appreciated the introduction from Nolan and Jen. We did, in fact, have a very short window to apply for this grant. And so just by way of framing, one of the things that when I got to the agency that so a fair amount of work had already been done to start thinking through what the projects would be that we would propose to CMS under the notice of funding opportunity that they laid out. And a big part of that was really thinking through projects that were already underway, things we had already tested, things that could be scaled, the work we were already doing under Act 68 and other previous healthcare reform bills. So we really tried to tie this particular opportunity with things we already knew we wanted to do or that were creating an opportunity that might not have otherwise been there. So that was sort of I would say the philosophy behind the work that we did to create the grant application, but also understanding that the notice of funding opportunity called for particular parameters that we had to follow. So we couldn't do everything we wanted to do. And there are some very notable things that aren't allowed under the grant that we'll talk about a little bit more. So where we are in the process, so we submitted back in November, we just submitted our revised budget to CMS last week. And we have our first annual report due at the end of August. That report is likely to determine what our second year of funding looks like. So we have a very short window to show progress in order to be considered in the second year of funding. We have a hard deadline of October 30th to obligate the funds and then another essentially year to spend the funds. So the track that we're on now is getting funds obligated.
I'm sorry, did you just say every year we need to
Reapply.
even be part of the overall picture, not even about the specific?
So yes, I mean, I think there's an expectation that all 50 states will continue to be awarded funds, but at the end, they're going to put any unobligated funds sort of back into the pot for redistribution in subsequent years. So yes, it's going to be an annual process of determining what the projects are and where we are and what our award is. Yeah. So our award was about $195 million, as I'm sure you've read in the news. We applied for 200 million. That was the instruction in the notice of funding opportunity. There was an expectation that all states would receive 100 million. That was essentially how the program was laid out. The second 100 million was what was in question. And there were three elements that determined that award, two of which we had no immediate control over. So there was metrics of how rural Vermont is, and the metrics didn't define Vermont as rural as we all think of it, because things like the square mileage of the state mattered in that calculation. So there was metrics of rurality, and there were also certain policies that were favored in the application that we had to have in place before the application went in. So those were things we could not control. The only place where we had any flexibility was in the strength of the application and the projects we were proposing. So in my view, and having talked to CMS, I think this is fair to say, We got the award we did because of the strength of the application and because of the strength of the projects that we were proposing. So it's something to feel good about, and it's one of the, per capita, one of the largest awards in the country.
Thank you very much for all the work that you're.
Thank you. So, and I think I said this on, that the unobligated funds are going to go back into the pot. We talked about that. Oh, yes, let's talk about cooperative agreements. So important. Thank you, my partner. And Tracy may jump in here. So yes, this is a cooperative agreement, not a grant. And I think the way I would suggest, this is what I've been saying about it. We get a lot of questions about the risk involved in taking on this particular opportunity. People are concerned about money being clawed back and what might happen in the future. I would say that the fact that it's a cooperative agreement is a protective mechanism, because what it means is high degree of oversight from CMS before they give us any money and before we send any money out the door. We expect under this agreement that they will have to approve every single subrecipient grant and contract that we put out. So line by line to every subrecipient and everyone who receives a contract. So there will be a strong paper trail of their approval on a line by line basis before dollars are released to us or awarded out. And so I think where the risk lies in this actually is being boxed in at the beginning around what the parameters are that we can spend the dollars on. And we're already, this week, we've already started to see some of that as we've gotten some feedback from CMS. I'm going to pause there. I want to talk more about what we're hearing from CMS this week, but I just want to pause on cooperative agreement before I keep going.
Thank you for explaining that difference. So you've also explained that there's a tight time frame really for expending the funds.
Yes.
And sort of this back and forth between the state and the federal government, and then never mind the sort of third party being the sub-grantee. That would seem to slow, result in not a very quick process, and may end up in resulting in us not being able to expend the funds within the time frame allotted. Do you anticipate that being a problem, or what are the things that we're doing to try to alleviate that? And maybe have you heard from the federal government about some sort of expedited review of things? Could you go into that a little bit?
Yes, I'd be happy to. So I do think that's a fair risk to flag, that we're going to sort of move fast and count the paper clips at the same time. So that's definitely a risk. The CMS has set up an office dedicated just to this grant or to this program, and they are assigning program officers to every state. So our current program officer is someone who we know actually from the AHEAD model. She's been at CMS for a long time, Kate Zapra, but we are getting our own. So she's the default for states that don't yet have someone in place. We will have a dedicated program officer to probably the Northeast. They're going to be based in Boston. So the idea is that we would have someone we can work really closely with, both programmatically and then also on the sort of business budget side. So they are, I would say we're seeing them really ramp up to being responsive. And so that's the evidence we have so far. I had to have our slides approved for today. It's that level of oversight. But I got them back in 3 hours. I mean, they did, I didn't expect that, but I submitted the slides and I did get it back with comments. So but it is a lot of back and forth.
So that seems to be as much a declaration to our potential community partners out there about how quickly they may need to be able to respond as well.
Yes, I think that's right. So we are working within the agency. We are all hands on deck, even though we don't yet have the positions that we hope to have available to us under this grant. Trying to get RFPs and contracts, grant opportunities and RFPs written now to release in February. So we just had a webinar earlier this week. There's been, I've said this every time I testified, a lot of anxiety, I think, in the provider community that we're going to leave them behind. And so just to try to alleviate that a little bit, because really they weren't hearing from us because we're trying to get our own ducks in a row, so we're ready to move. We felt like we really needed to share that. So we've now set up, there's inbox, if people have thoughts or sort of ideas that they want to share with us as we're doing our planning. There's a dedicated inbox on our website. And then there's also a dedicated listserv where people can sign up to subscribe for updates. So hopefully they'll then get a push out when we're putting out RFPs and grant opportunities, so people can be notified and don't have to like track the website every second. So we're trying to just help people understand. But yeah, and I think the capacity of the provider community to respond is going to be one of the challenges of this that we're going to need to find a way to.
And you're going to get specifically into the timeline and spending timelines later in the presentation.
Well, yeah, we can talk about that here. Go ahead, Tracy.
And I think I would just like to highlight that our partners at ADS have been working with us to procure an electronic grant management system that will help providers apply for these grants. So it will be done through email back and forth, but we've put out an RFP. We've received some bids, and it will be an off-the-shelf profile based. So perhaps they can apply for multiple grants at one time, and we will be able to communicate with them more efficiently.
So in terms of the timeline for approval, has CMS officially approved your entire budget at this point? Have they approved part of it? What's the timeline for them to really, and can you start work before everything's approved? And so what's that sort of timeline where everything's supposed to be completely approved?
I don't think there is one. I think it's going to be back and forth and back and forth and back and forth. And so everything has to be approved before the dollars can be released project by project. And so I don't really think there's going to exactly be a finish line. It's going to be that we have to work through each project and then the subrecipient grants and the contracts with CMS. So they're going to keep asking us questions all through they have 30 days to respond to our last grant or our last budget submission, which was on Friday, and they've already started. But they could keep asking us questions.
So if they've approved one section, can you get to work on that section?
Yes, and that's what we've seen with the AHEAD cooperative agreement. That's the same model, is that they'll almost put like a hold on it to say, in concept, we agree with this project, but once you know the subrecipient and their budget, give that to us, and then we will release those funds for you to be able to draw down.
Yeah, so it's going to be a very dynamic process.
Just to follow up on that question. So your budget in the AA1, is that what you submitted, or you submitted a more detailed budget, or is it?
I think it's more detailed. I don't remember what's in the AA one.
Are you talking about the cover sheet?
Yeah.
That breakdown? So that was based on our original submission, and now we have a more updated budget that we circulated this week because we just submitted on Friday. So that has shifted a little bit. For example, the staffing plan, once we realized we were going to be receiving 195 million, we thought we would need more positions. So that.
Well, that's what I was wondering. It did seem like there was enough money in there for that.
If you say that.
There wasn't enough money in your AA1 for.
And so now we've just boosted that.
Okay. Thank you.
Okay, back to you.
Okay, so I will say one more thing about dates. So really what we're trying to do is get as many RFPs and contracts out now as we can to try to get the funding. Our internal deadline is to get funding obligated by August 1, so that we're ready for that August 30th report. And then, but there are some projects that I think need more development work that may take longer and may get sort of bumped up against that October deadline. So that's going to be something we'll have to work through internally. But there are some projects that just need, I think, more development and sometimes kind of multi-department development with multiple stakeholders. So just more like how we improve the way we transfer individuals from one setting to another involves multiple types of providers, multiple departments. That's going to be a tough one.
And even though we don't have appropriating power over this the way we did with, say, a lot of the COVID funds, we're still going to want to closely sort of monitor spend and progress, because it's really important work that we care about. So we'll keep on looping back with each other about this.
Absolutely. We would expect that. And I think, again, we'll also continue to try to make sure that what we're doing is in line with our broader healthcare reform goals. So one of the reasons we're talking about transfer centers at all in our application, for example, is because we did all this regionalization work coming out and transformation work coming out of Act 68 and previous bills. And that was what we've started to hear on the ground, that this was a real problem that needed some work. And so I think there's already a fair amount of synergy. I'm hopeful in terms of the goals. So I fully expect that it'll be both specific to this that we'll be having conversations, but also broader healthcare reform, because this is a tool in the healthcare reform toolbox. It's not our plan.
Thank you for saying that.
And finally move on to the next slide.
Thank you.
So let's see. I think some of this I said, the NOFO or the Notice of Funding Opportunity outlined the areas of focus. So those, and I think I have those on the next slide, that we had to consider. We are thinking about this as one-time funding. So we're trying to start things up. We're trying to pay for stuff. We are trying to bridge gaps. There's some programs where under the all-payer model, there's no longer funding available. There may be future federal funding available through the HED model or some other model. So we may be bridging, but we're trying not to add to the base or create new programs. There's a few possible exceptions, things that are in place now that we really want to keep going. We may have to come up with our sustainability plan, but every project has to have a sustainability plan per CMS. And we are really focused on not adding to the base. That's definitely something that is part of the sort of underlying philosophy of this work. This gets the funding limitations, I think, gets back to what I said before about where I think the risk is going to be on identifying allowable uses of the funds and useful projects because of what we can and can't spend money on. So one thing we can't do is supplant the state budget. So we can't say, oh, there's something we typically pay for in the base budget and we're going to start paying for it with this. Now that's different from things that we've paid for with one-time funding or where a program has ended and we might start it up again. So there are some examples that might come to mind where you say, well, why is that in there? That's why. So we don't think it's a supplantation. Probably something we're going to have to keep a close eye on to make sure we don't make that mistake. We can only do minor renovations. And so if we could do major renovations, we have a lot of healthcare facilities that could use real work, and that is not an allowable use of these funds. So the examples we're starting to hear about are things like buying partitions and vent covers, like things that are much more minor, because we can't increase property values in the effort in this spending. So think about that. So I hope that so we have one project, which is to increase the number of nursing homes that have some high acuity equipment like vents or even dialysis units. That's something that doesn't exist at all. They're going to have to reconfigure their facilities in order to install those things. So that's the kind of negotiation we're going to be having. Yeah.
But not build a wing.
But not build a wing. Right, exactly. We can't use the funding for otherwise billable services that we're already reimbursing for. So there are some things like the Blueprint for Health PMPM payments are actually not otherwise billable. So those are in here, but that's going to be something we have to check for that if it's a clinical service that it's not already billable. And then this is new this week. So I've had 2 interactions with CMS this week. One in writing and one on the phone. And in writing, what they said was that our provider payments cannot exceed 15% of the total award, which is about $29 million. And so the conversation, and they identified certain projects that they thought were provider payments. On a call with the program officer, they identified an additional project that might have this implication. So we're going to need to go back in and take a look at all of our projects and get further clarity on what's meant by a provider payment. It's definitely focused on licensed clinicians. So I don't think it's going to be organizations, and I don't think it's going to be unlicensed clinicians who might be providing services or supports. But I think this is new, so you're hearing it practically as I'm hearing it. This one's going to take some effort to parse it, and of course, paying providers to do things is an important part of what we are hoping to do with these dollars. And so having a cap is, again, potentially boxing us in.
So the question about the billable
Yeah.
services. And then you said it's the reimbursement or payment will be by provider. So is it by how we are currently paying for services, billable services? And if we have a new provider, can we include them, or is that out?
Oh, no, I don't think that that's out because well, what did you think? Your CFO? Let me ask my CFO.
That's an interesting question.
Yeah, it is an interesting.
Like if there's a provider who comes in after you, yeah. Like if there's a new practice, for example, on the blueprint, is that what you mean?
Yeah.
Yeah, okay, good question. We'll take
Okay.
that back. Yeah, again, this is gonna be dynamic and we're gonna really need to think through how to make what we want to do fit with what we're allowed to do. That's our goal. We want to spend these dollars. Yeah, I think that's pretty much it for that one. Yeah. Okay, these are just the initiative categories. I don't know how deep you're gonna want me to go into the projects. I don't find the initiative categories as helpful for how I think about these projects is the next slide. You go to the next, there we go. Oh, good, it just was close. So, there's, I don't know, 40 projects, 30, a lot.
Yeah.
I can speak to almost all of them at a high level. I have found in testifying on this, in other committees that it's really hard to get through all 38 of them in testimony. So I'm not about to attempt that, but I'm happy to go deeper to the extent that you ask me to. But broadly speaking, our plan calls for, we're really trying to strengthen our rural health networks. So that's building on primary care, supporting transfers, as I already talked about, really using EMS in a new way, some of the EMS work and creating mobile integrated health and finding ways for EMS to really provide additional care in people's homes and in the community, and be reimbursed in a new way. Like that's really exciting work. So that's a piece.
Jill, I'm so sorry. I would like you to go through all the projects, and what we're gonna do is
Okay.
we're gonna hold all questions until you're done going through all that.
Okay, then I think we want to look, if we're gonna do that, yeah, that's one way to look at it. There's also the budget narrative has like a list.
Whichever you prefer.
I think for me, I think you may like that document. Yeah, I can go from there. That's fine.
Should we switch to that?
Yeah, let's switch. Do you have that one? Actually, you know what? I have that in front of me too. So hold on a second.
We have that electronic.
And
Which one is that?
I think we received this.
Doesn't have a title on it, but it's the 40 project. Just from her testimony before,
Found it, yeah.
might be easier to read online.
yeah, it's just not very, what do you call it? I can't think of
It's a
the
lot
word.
of info, yeah.
It's just hard to project. Yeah. Okay. I'm gonna go through every project. I need to ask for a little grace. I'm not a subject matter expert on every single one of these things, but I can speak pretty broadly to what we're doing.
We're not gonna ask any questions until you're done.
Okay. All right, here I go.
Right.
No, we're not. I'm not gonna call in anyone.
And I'm gonna keep my eyes down, so I don't even get tempted or tempt you to ask me a question. Okay. Everybody have the document? Okay. Here we go. Yeah, go ahead.
It's sorted by department and then the type of award and activity number. So it's not by initiative.
Category.
Yeah. But so we might bounce around on the initiative piece.
Okay. Development of a statewide healthcare delivery strategic plan. Act 68 called for that. It allowed, and Act 68 allowed for for transformation grants for both hospitals and non-hospitals, but didn't really allow us to hire help, a contractor essentially to help us develop that plan. I think we need that. I think we need a external structure and expertise to help us with that. So that is what that project is. The independent evaluator is essentially required by the grant. We need someone to see if we're doing what we're supposed to do. So that's that. Transformation analytics and support. So Act 68 allowed for us to hire an analytics vendor to help with technical assistance to hospitals on transformation, the transformation work they're doing, but it was only 1 year of funding. So this allows us to continue that funding over a much longer period of time to provide that technical assistance longer. Facility upgrades to support regionalization. This is one I expect we're going to have to adjust because we're hearing about caps in this category too, and also the change in the kind of the definition of what is and isn't allowable, I think is going to change this number. But that's essentially assisting facilities with their changes that they might need to make to further support regionalization or transformation. Supporting a closed loop referral system. So this is a digital technology that gives more information to physicians when they provide a referral about what that person did about that referral. Did they go to that specialist? Did they make the appointment? Did they see that specialist? And what happened? And I think we're all frequently surprised at how even today our system is not especially coordinated, and this is a tool to help with that coordination. Transformation, innovation, and regionalization support grants. So this is again trying to help our providers create these regional strategies to essentially bring our healthcare system into match today's world. Part of what we really want to use these dollars for is to help solve some of the underlying delivery system issues that contribute to our affordability challenges and that contribute also to our access challenges. So we're trying to use these dollars in a way that supports access, but also considers what kind of access do we need where, and also quality. There may be some cases where we feel like care would be better off, more regionalized in order to improve quality so that there's more volume and more specialization. So we've done some of this work already. This is really funding to help providers participate in that. Again, given this cap that we're talking about, I think there's more work to do here now to understand exactly how this works. Statewide health data platform, modernization and transparency. This is something that the Green Mountain Care Board requested, and it's a price and quality and data tool that would be something that they would make use of. They gave us a full proposal on this. I have to say, this one I can't speak to in much detail, but it is a tool that they asked for, and we felt it fit under this grant. A shared human resource information system. So one of the things that one of the strategies for increasing affordability is to identify areas where hospitals in particular can share services, back office services, and an HR, a unified HR system where they're all purchasing into this one system. It wouldn't be that they were sharing data, it's that they would be sharing the purchase of the tool. Was something that we heard from providers that they would find useful. I think standing up some of this back office functionality is a good use of these dollars. If we can get it stood up and implemented, because there's usually startup costs when organizations implement new systems that they may be able to carry. We would expect that they would carry the operating costs, but we would help get them going. Incentivizing adoption of a shared EHR, electronic health record. So first, I want to say we are not mandating that everybody get on the same electronic health record. That makes everybody really nervous when they think that's what we mean. It is not what we mean. But we were hearing from hospitals that one of the tools some are interested in to accelerate our healthcare interoperability of data, which is an ongoing challenge to find ways to make healthcare data interoperable. If organizations are on the same instance of the same health electronic health record, they can more easily share data. So some are interested in this, and it was something that we felt was a good use of these dollars. Again, it would be to get them up and running. There are some limitations here. There are previous federal dollars that some hospitals used to stand up electronic health records. So there's a limit on how much we can give someone who's already gotten other federal dollars.
Is that clinical and claims?
No, sorry. Thank you, Madam Chair. And Grants to providers to adopt AI transcription and scribe technology. This is something a lot of providers are really interested in. For smaller practices, it's cost prohibitive. Okay. Blueprint one's maybe a little mushy here, a little mixed up. Let's see. I'm on, I don't know. Did I? I did AI technology.
Yeah, we missed it.
Oh, we did? My CFO says I missed some details. Oh, yep, I sure did. Thank you, sorry. So I moved back up. So EHR, now I'm on eConsult. So eConsult is essentially, it allows for interoperable, it essentially makes it easier for specialists to assist primary care in rural areas where the specialist might not exist at all. So it's a tool to assist with that. Oh, yeah, I think it's just the way my
Yeah.
screen is just large for my eyes, my old eyes. Thank you. And it was, okay, I'm good. So what did I miss?
From remote patient monitoring.
Oh, remote patient monitoring. Oh, I love this one. Okay. I'm gonna look at Tracy's. I don't know why mine is like not, it's flipping too fast. Thank you. So remote patient monitoring is a great strategy for rural areas. This, and really for anybody. I think we all know that when a person who is has multiple chronic conditions and might be medically pretty frail, needs to go to the doctor, that is a project, often a family project. And so to the extent that we can monitor how people are doing with multiple chronic conditions in their homes without asking them to go anywhere, it really improves our ability to identify problems that might be exacerbated before it becomes a need for an ED visit or an acute hospitalization. So home health agencies have implemented remote patient monitoring. Primary care practices have. It's not really paid for by anybody, and so the equipment isn't really paid for by anybody. So at least assisting them with the purchase or the leasing of the equipment to help them then be able to get this data on people's essentially vital signs, their blood pressure and other things, so that somebody else is sort of paying attention to the critical indicators on a chronic condition. This is just a visual. I cannot literally can't see. Yeah, sorry, I'm getting my partner in crime here is helping me.
Next thing I see is telehealth.
This one? This one. Oh, yes, telehealth. Thank you. My eyes are old. Yes, grant funds to providers for telehealth technology. I think we all know what telehealth is, so I'm not gonna spend any more time on that one, actually. AI I talked about when I skipped over, and then I hit the blueprint. So the blueprint for health is our current primary care. It's a primary care initiative that's been in place in Vermont for a long time. It includes multiple components. So it allows for community health teams who can help enhance the care provided by a provider. So it might be social work assistants or some other kinds of sort of wraparound experts to assist in the care of people, because often healthcare needs are actually go well beyond the sort of clinical need that you might want to talk to your doctor about. So we're creating new PMPM payments for community health teams that will combine. The idea is to combine some sort of disparate payments that we already have in place for different types of services. Blending them is going to have, there's going to be some complexity there because not everybody does everything, but that's part of the concept there is new PMPM payments to support community health teams. Integrating mental health into primary care practices. PMPM payments, that's per member payments for Blueprint primary care providers, especially to support them in doing things like increasing access or doing more care coordination. It's essentially an add-on payment to what they're already reimbursed. So it's really asking them to do more coordination. Let's see. Yes, because it's hard, a little hard to talk about these things separate because they kind of fit together, but the idea is we're modernizing the Blueprint. I think that's the big picture, and bringing mental health and substance abuse further in, and then trying to create these more modern payment models. And then provide some tools for those practices to help with that provider or with that family engagement and just understanding where people are. I think one of the things that's always been in terms of our taking care of people who have chronic diseases is that it's always been less coordinated than would be ideal, right? Like the ability of physicians to understand where everybody is in their care. It's just, there's a lot of work to do there, and the Blueprint has been on the forefront of improving that. It began with focusing on diabetes. We really need to get it more into into more chronic conditions, depression, congestive heart failure. So there's sort of a series of 5 or 6 projects that are all together a Blueprint modernization. No? I think I talked about mental health into primary care. Yep, that's one of them. Yes, I think I talked about all of the Blueprint ones kind of together. Is there one I'm missing?
There's an FQHC Blueprint.
Is there? First data. Oh, that's different. Yeah, okay, that's not Blueprint. Yes, so this was actually the FQHC project. I think we're gonna be looking at it again. So there's an effort in the Brattleboro area to open a new FQHC, and there were some ideas in play at the time that we've submitted the application that we thought we might be able to support. I think the plan is changing, but our goal of expanding access to federally qualified health centers in that part of the world remains. And so I think the what needs some work, but the interest remains. Oh yeah, these are just in a funny order. And so this is the next one is the PMPM payments that I already talked about for practices. We've been talking about that in your committee, Senator. And then combined payments for specialty and primary care to try to sort of incent the primary and specialty care to work together. I think I did all the Blueprint ones. I'm just going to pause because Senator Lyons. Oh, no questions.
No,
I forgot for a second. Okay.
You challenged me.
I did. That was.
Get through this whole thing.
I know. Here we go. Let me keep going. Okay.
No, it's gonna make it.
Wow. Okay. Access, high acuity services for nursing homes. I talked about that earlier. Dialysis and vents in nursing homes, increasing the acuity of care that a nursing home can take will, I think, improve our ability to discharge complex people from various other settings. Okay, I think we're hitting some workforce, LNA, yep. So expand access to LNA training programs. So many of our nursing homes have, or some of them have LNA training programs. So it's really trying to get people who might be entirely unlicensed to this first level of licensure. And it's a critical, LNA is a critical, a critical team member in long-term care. And so this is a project that would bring people, create training programs in, or fund training programs in skilled nursing facilities to bring people along while still working, but also hopefully to create some kind of more of a hub, especially for smaller facilities or organizations that can't fully stand up a program. That's kind of 2 ideas. Mental health and substance abuse and essentially expanded urgent care for mental health and substance abuse. statewide e-consult expansion. So this is actually, I already talked about the e-consult. This one is in a different spot because it's a different department because we do have an existing consultation for child psychology program in place that's about to run out of funding, and we're hoping to bridge that gap using these dollars. So we have 2 places. Assessment of options to improve health coverage affordability. This is mostly related to the looking at the waiver, the marketplace, qualified health plan marketplace reinsurance, which is part of H585. So this is funding to do that. Mobile units for integrated mental health and substance abuse disorder treatment, mobile units for dental care. The Maple Mountain Consortium Family Medicine Residency. This is essentially a physician residency, a rural physician residency. And this is one of the few named subgrantees, the only named subgrantee in the application. Expanding pharmacist scope to include test to treat in more scenarios. So literally pharmacist testing and providing treatment, no doctor in the middle. Community paramedicine, mobile integrated health. I think we talked about this. So we were really trying to use EMS in a new way. Community medicine in the essentially using that workforce in the community, pre and post operative, and in other ways. Also, part of it is also thinking about how they're paid, because right now EMS only gets paid when they take someone to the hospital, which is not that useful. That's not the best place for that person to go. There's a lot of work here to do on EMS. We talked about interfacility transfer. So this is figuring out, we pitched it as essentially a tool. Other states have created a tool, but I think there's a lot of work to do to think through the problem statement and how to best solve it. But we need to improve how transfers happen between different facilities and different types of facilities. Expanding access to recovery housing. I actually think this grant is going to be a great use of these dollars. And the health department is, I think, pretty excited about that one. Workforce tuition assistance. So this came out of a project that the designated agencies have, but we wrote it in a way where it would be something they could access, but so could other providers. We tried to keep things flexible. And this is assisting people with things like licensing renewal fees, exam costs, continuing education, really just trying to help keep that workforce, keep our workforce strengthened. Invest in we had a program, a critical occupations no cost tuition program at what was then Vermont Tech. This would stand something similar back up for certain healthcare occupations. The conditional financial assistance program. This is a project that we did get some skepticism from CMS yesterday, so we're going to be working on this. The idea here is to provide financial assistance to a wide variety of types of providers or people who want to train to be types of providers, nurses, radiology techs, medical technicians. But we have to, according to the grant, or the cooperative agreement, the NOFO really, we have to have a 5-year service commitment. And so the idea is to have a sort of promissory note debt component to people who don't meet their service requirement. It sounds like that maybe we have to work on this one, but that was the concept there. And then healthcare professions residency. So when we think of residency, people often think of physicians. In this case, this would be nurses, home health nurses, for example. It's really hard to be a new nurse and become a home health nurse, go down a long dirt road by yourself. So home health in particular is an area that really appreciates residency programs. But the idea here is training for people on clinical sites. I think I did it.
You did it.
Good.
Senator Lyons, do you have a question?
I gotta remember what it was. In just a couple things, and I think there's a lot in here about primary care. So you have the blueprint, and then you have other primary care enhancements. And so is there a distinction there? And also, Dulce has been a big part of primary care, enhancing that. That's a question I have. How are the distinctions being made? And then I have a more general question for you.
Okay.
I won't ask all my questions now.
Okay. So all of the primary care is really about modernizing the blueprint. So the blueprint is the foundation of, I think, all of the primary care work that we're planning to do other than this FQHC expansion idea. I believe Dulce is one of the payments that we would consider trying to figure out how to integrate. So there's development work happening now by people who are much better subject experts than I about exactly how to modernize these payments and use these funds. So I think there's more to hear about that than I can speak to here.
Okay, and can I ask? You're very pleased. So then, obviously, there's a lot of emphasis in here on workforce and a commitment. And most of the workforce that I'm seeing or I'm thinking about is the medical side of treatment. And rather than, if you're going to have a community health team, you need to have a full team of social services, mental health, substance use disorder. What is in here for that?
Not much. There were limits on our ability to provide something like a loan repayment for physicians. It was an excluded, it was excluded from the NOFO. We couldn't do it.
Wasn't your question the opposite of that? Not the opposite, but like more like for social workers or something like that?
Yeah, social workers, I mean, so you don't have social workers in?
Oh, no, okay, so two things. Okay, let me answer this two ways. In the grant, we tried to leave it, even when we listed the different types of providers who we might want to provide support for, we tried to sort of say, and the rest wherever we could, to leave room if we failed to list something that was important. But our intention was mental health and substance abuse, home health, all levels of nurses, long-term care, anybody working in long-term care, social work, radiology techs, all of the levels. And so it may not everything may be listed. We were working really fast, but we tried to leave things flexible. But physician loan repayment was excluded as something we were allowed to do, so that you don't see that here because we were not allowed to put it in.
Questions? I'm glad you brought up the FQHCs, and we won't dive into the Chittenden County issue right now, but Chittenden County is excluded. I think people need to know that, which is unfortunate because it's a reservoir for care. We've been through that in our committee. The other question is, there's in here, you talk about this is a voluntary process. So having a voluntary process, what incentives are going to be in place so that we don't end up with failure that we felt with the ACO, which was voluntary?
So I think that may be outside the scope of what I can talk about here today. Yeah, because that's part of the development work. And I think I expect to be talking about that very question in your committee as we continue with the primary care bill.
I'm gonna ask a question.
Oh, somebody else.
I just want to follow.
We should talk about Chittenden County. I do want to talk.
Yeah,
about that.
I thought in your testimony in our committee, you explained that people say Chittenden County is excluded. That's not really.
So there's updates. So I should probably just start over about where that's at. Yeah. So the question is whether or not how Chittenden County is or is not included in rural health transformation. There are no providers who are sort of a priori excluded. But CMS has said to us, they said it to me on the phone yesterday, and I'm hearing this from other states, the expectation is that the services that we paid for through rural health transformation will be in rural communities. So you could have a Chittenden County provider providing services in a rural community or in multiple communities, but it's going to hinge on the rurality of where the service is being delivered or the people to whom it's being delivered. When I initially testified on this, it looked in our application based on how the NOFO was structured. We were using the HRSA definition, which fully excludes Chittenden County. It sounds as though there's going to be somewhat more flexibility than that. We're waiting for a new FAQ from CMS, but I don't think there's a world where Burlington is going to be considered a rural community. So I think this is still a bit of a work in progress. But that was what I heard from CMS. So I think this is actually something we're still working on. But again, services provided, it's what's going to matter is who is receiving the service, not, or the benefit of the work, not where the organization is located.
Okay.
So more to come.
My question, actually, I brought up the FQHC before just because it was the next line that I thought you hadn't covered yet.
Yeah.
So I was particularly interested. I'm curious about the relationship between the independent evaluator, whether that's really like an auditor, like a fiscal auditor capacity, or really like a monitoring and evaluation capacity, and the relationship between that and the statewide healthcare data platform modernization and transparency initiative, and if there will be, the evaluator will have a dashboard, if those two things are linked at all, and sort of how Vermonters are going to be able to follow like outcomes progress in real time, or if that's a goal in any way.
Yeah, so there are different things. So one of the things that you mentioned, I believe, is the tool that the Green Mountain Care Board wanted on sort of price and quality transparency, not just for this program, but just writ large. So that's that. So I have to say, I probably need to look back at exactly what we intended on the independent evaluator. I think it might have been required in the NOFO.
You said that before.
Yeah, did I say that already?
You did that.
Okay, well, good. It is, and my CFO is saying I'm correct. So I don't know why I'm uncertain now, and I was certain before. But there are, what I haven't said yet is that there are a series of metrics that we promised to CMS. We had to have metrics. We tried to, and I think this is really challenging because some of them, we had to have a combination of outcomes and process measures. So process measures, yeah, as you should, yes. But process measures are easier. It's easier to say we did the thing, or we provided scholarships to this many people. That's easy to count. Did we move the needle on vacancy rates? Much harder to count, harder to know if this is the deciding factor, but we do have a blend of both, and exactly how the evaluation of this project impacts our ability to receive funding in the future, I think is something that we'll continue to talk about. And it's challenging to look at outcomes, especially in a short time period. They take a long time those needles don't move very fast.
Especially the state primary care. Yes.
Yeah. Yep.
I'm done. I'm good. I mean,
Really?
not done. I'm just good. Yeah.
You got it. Yes.
Yeah, I'm curious just because you're talking about accelerating some existing programs, starting up others. How did you develop the list?
So we developed the list as essentially the healthcare reform team, in partnership with the secretary, tried to make sense of this along with, receiving various inputs from the provider community in particular. They were pretty interested and sent us all kinds of ideas. So it was a combination of, and we had the inbox already set up. So it was a combination of like some incoming ideas, but really, I think I said this at the beginning, the secretary really laid out a philosophy of let's look at what we're already doing or have already wished we could do that we want to scale up, spread. And that was we really tried to look at the healthcare reform work that we're already doing and how can we make this tool fit with work we were already committed to. So that was I would say the philosophy of how we selected the projects and then laid out against what the grant could actually be used for. So we had to kind of combine all of those things. And I'm new to state government, but from what I understand, this kind of time frame from NOFO to deadline it's beyond fast. I mean, it was really, really fast. Part of why we tried to leave some flexibility, for example, the transformation grants, we tried to leave some room for further development, knowing that we would need to do some more thinking.
I'm gonna ask you to go back to the presentation. Unless someone else edits me. Oh, yeah. go ahead.
So Joe, on the items where it does talk about renovations of buildings,
Yeah.
not going to be allowed, is that money still going to stay in that category, or are you going to move money around category? Okay.
Yeah, I mean, I think this budget's already out of date. Yeah, we're gonna have work to do, and I think we're gonna be addressing it actually pretty frequently as we negotiate with CMS.
Yes.
That was
kind of my question too, to take it a little further, if, when you move the money around, are you able to add another project? If one is not acceptable, or do you just end up modifying existing products or projects or expanding them in some way to?
So I don't know for sure. My sense is that we will, especially in this first year, we will really need to focus on the projects that we've already outlined and have things fit under the categories of projects that we've already created, given the pace. But then, of course, we're going to be heading into, as we're doing all this work, a second year. So exactly how that works, I'm not sure. My view is that we need to sort of stay in close touch with how all of our healthcare reform plans and efforts, and continue to think through how we might make adjustments. But some of this is not fully clear to me yet. I think we'll know more as we continue to negotiate. You can talk about different positions. Sure. Okay.
So this slide is our proposal for the RHT staffing plan. Again, in our initial application, we requested 15 funding for 15 positions. Once we received the actual award, we knew we were going to need additional resources. So now the staffing plan is at 21 positions. The 2 positions highlighted in green are what was submitted with the AA1 packet. So we are looking to establish those pretty quickly because these are the ones that will be coordinating with CMS on a quite frequent basis as we make updates to the grant.
These are the positions that are going to let us get a little bit of sleep.
Yeah, bring it back to sleep, but I didn't want to ask.
It's not really a thing for us right now.
Yeah. And then I'd like to just call out the positions highlighted in yellow. Those are existing limited service positions that we would like to repurpose towards this staffing plan. The bulk of those are HCBS limited service positions, and that spending plan is just about done. We have about 6 months left to go, but only a couple projects. So it's actually a great nexus for with their skill set to start.
Remind us what HCBS.
That was the 10% additional federal funding that we were able to draw down for home and community-based services coming out of the American Rescue Plan.
A couple of staffing questions. Sure. So the yellow ones, you have people in those positions now, and you're going to repurpose the people, or are some of those already vacant?
The combination.
Okay. And in terms of the 2 green ones, which are, you guys kind of, but right for now, but critical positions, are you hoping to be able to hire internally? Or I'm a little worried about how the hiring process and how long it would take, and then finding somebody who hasn't worked in state government. And when we had
Like me, you mean?
When COVID happened and we got hit with $1 billion, Douglas Farnham moved to be the chief recovery officer in state government. That became his full job. So I'm sort of thinking this is an equivalent of what he's doing, but for your project, but having somebody in. So I assume you kind of have plans for as soon as you get the go ahead, ready to put somebody there?
So we do have to post them for recruitment per normal process. And so we did that in anticipation of getting this approval. So I think we both have hiring lists, and hopefully we can start interviews next week. Yeah, and I'm happy with the candidate list.
Yeah,
that we've received.
I'm very hopeful.
And what about the white positions?
Then the white positions would be new limited service positions that we would seek as part of like the phase 2. This would come in a subsequent packet that we're assembling. The team's putting together the RFRs and just the whole packet. And so we hope to get that over to you in the next week or 2.
And those are 1-year limited service positions because the funding is just going year by year for this 5 years.
Is that what I put in the first one?
No, I think you have 5 years.
I did put the 5 year, so
That seems like a nicer thing to apply for.
Yes.
Okay, great.
Okay. Oh, yeah.
Yeah, so I'm just thinking about all this, and we have a lot to do by August. But it has to be obligated.
Obligated, correct. So
And then
that means
spend, yeah.
written agreements.
Yeah, so you have-
Or contract. And
You have 6 months or less to obligate $195 million.
and it is all hands on deck with all of the AHS departments. We have farmed out this work to start writing RFPs. So we can get things posted sooner than later.
So you've started,
Oh, yeah.
and you have some sort of checkbacks and balances to make sure you're on track? You have some system in place for your process to be doing that?
And we're building it, yeah, we're building the tools.
Yeah.
You know, this is definitely an airplane that's already in flight,
Right.
but yeah.
I mean, yeah, we have multiple meetings every week, but as we get staffed up, I'm sure there'll be more of
Yeah.
a coordinated effort, just like it was for the HCBS spending plan. Honestly, we had already had that framework where we had a number of activities, about 100, and that were spent at all the departments. And in the healthcare reform office, we had a person that was coordinating that and keeping track of that. And, you know, 'cause we have to do so much quarterly reporting. I think we have some experience in that area.
Some of us do. The agency definitely does.
Yeah.
I'm just curious on these positions, and given the amount of technology that's being proposed, I don't see anything for ADS here.
That's a great question.
And given the,
Or CNF.
given the considerable work that they are already undertaking, and maybe having difficulty completing in timeframes that we wish it could be done, I'm just inquiring that you may want to revise this.
I think we'll take that into account for sure. For the grant management software, that 300, we did budget $350,000, and that was in coordination. That budget was developed with them, thinking about the licenses and their work. I think we'll have to assess which IT systems will live with the state versus out with the provider community.
Right. I just am imagining that we are going to want to make sure as a body, that whatever, even if it's managed outside of the state, that it meets the elements that we would want to expect from this kind of investment. And I would think that we would need the expertise of people from that agency, just a thought.
Yeah. I really just have one last slide, which is just to talk about our community engagement. I think I've actually already talked about this. We do have an RHT program page. It has a public contact form. It has our narrative, essentially our original submission to CMS, a summary and a list of projects. We're going to need to be updating some of those as we go. And then it also has the instructions to sign up for our email list. And then just to say also, and I actually don't think I've said this, we've done a lot of work to leverage existing committees, expert committees. So for example, in our workforce projects, there's a standing workforce strategic development committee that was created by this body, and they had done a lot of work to plan and recommend what kinds of workforce initiatives they would like, and that's what you see reflected here. So we're leveraging the primary care steering committee. There's other groups that we already have stood up and available to us who will continue to leverage this process. I think that's the last slide.
Thanks. Any other questions or documents that folks would like to read from?
So you guys have done an amazing amount of work. And I think we all want this to be successful. I know we have virtually no ability to do anything in the legislative body, but I'm wondering if there are any ways that we can be helpful to you other than stay out of your way. Or have you even thought about that?
So I actually think where the partnership is going to come into play is continuing to make sure that what we do with these dollars, especially over time, is lined up with the healthcare reform goals that we usually agree upon together. So to me, I view this as, again, I'll say it again, rural health transformation is a tool in our toolbox. It's not our plan. And so I think as we continue to do the work that's been asked of us by particularly healthcare committees, we will continue to think through how to connect the dots between this particular opportunity and the work that we're mutually agreed upon to do. So I think, I do think there's more room for that in the out years, but yeah, right now I think we just have to put our heads down and go. Yeah.
Any other questions? Anybody have a? If you could make that one, the one that, yeah. So in order for us to stay coordinated on all of this work and making sure that we are tracking we have a responsibility to track your work closely enough that we can stay aligned. We're hoping to get regular formal updates from you. And to make sure that the Joint Fiscal Committee is not the only one doing that. For instance, the chair of the House Healthcare Committee is not on the Joint Fiscal Committee. We're hoping to formally request regular updates. So just wanted to first check in with you to see if that's.
We expected that you would want to have some regular updates. What I hope we'll be able to do is repurpose we are going to be doing some submissions to CMS. So hopefully we'll be able to, my preference would be for the request to not be very specific so that we're able to repurpose what I expect to be a series of requirements from CMS about how we report things. So we have some flexibility there to give you what you need, but also use a format that we're going to be already using.
One of the things that would be, I guess by way of feedback is, so during particularly this period of time when we've been taking budget testimony from individual departments, and we continue to hear, particularly in House Human Services and House Healthcare, I'm sure, sort of the statement, we believe that could be funded by the Rural Health Transformation Grant. And I'm seeing some things and hearing some statements from you that are directly not opposition, but different from that, some specific things. And all I'm trying to get at is, I guess, wanting to ensure that individual departments are like really clear about things, and it'd be helpful if people don't say things that they think that it could be in the grant, when some of those things are pretty clear that they're not in the grant.
Okay, yeah, so I agree. I have gotten requests from a couple of departments to confirm that things are allowable or likely allowable under rural health transformation. So SASH, Blueprint. There's another one from Dale that's just escaping me, but I know they asked me about.
You didn't ask about SACH, I was going to, but thank you for bringing it up.
Yes, yeah.
The other one was around loan repayment and tuition, and that's.
Oh, yes, no, that's
pretty clear that's a.
No, well, sort of. No, I think that's let me clear that up, actually. So we had this program through VSAC that's been essentially a nurse tuition assistance with it turns into debt penalty, I guess. Okay, that Senator Westman is nodding, which means I'm not way off track. That's in here. That's the one that actually I'm now, though, hearing that we literally heard yesterday, they may have some concerns about. So yes, we put it into rural health transformation, and yes, we intended to fund that project with this. The one we're not funding is physician loan repayment, could not go into this.
That's
so
what
maybe some confusion there. Okay, I can clear that up. We can talk after about exactly where that was. I will clear up any confusion. This is very fast moving, and I do think it's maybe hard for
people, but yeah.
We'll just make sure we get everybody aligned. Absolutely.
You're getting new information every time you have a conversation with CMS, so I get it.
Yes.
I guess what I would ask you to follow up on that question is, I imagine that you don't have time to come into every committee to verify whether something like that is accurate or not whenever it comes up throughout the budget process. So for you to just you don't have to answer this right now, give some thought to what the actual best process is for us to be confirming that on an ongoing basis as we get through the budget process.
We have several in ours.
It's, and, yeah, it's come up a number of times already.
Okay, let me give that a little.
Yeah, just give it some
Talk
time.
about that, like, yeah, we'll figure it out. Okay.
Any further questions on the grant from anyone? Would love a motion to accept it.
I will make a motion. I move to accept, grant request 3272 in the amount of $195,053,740 to the Vermont Agency of Human Services Central Office from the U.S. Department of Health and Human Services, Centers for Medicare and Medicaid Services for the Rural Health Transformation Program, and to approve 2 limited service positions, 1 position to the AHS Central Office, that's Financial Manager 2, and 1 position to the Office of Healthcare Reform Integration Manager.
We have a second. Representative Shy moves that we accept grant number 3272. Senator Lyons, seconded. Any discussion? Seeing none, if the clerk could please call the roll.
Sure. Senator Beck, yes. Senator Cummings,
Yes.
Representative Feltus,
Yes.
Representative Kimball,
Yes.
Senator Lyons,
Yes.
Senator Perchlik,
Yes.
Representative Shy,
Yes.
Senator Westman,
Yes.
Representative Wood,
Yes.
Representative Kornheiser.
Yes.
Right.
What's the vote?
How many of us are there? There are 10-0-0.
Thank you so much. And I believe we have a second.
Second motion. Okay. I move to require the Secretary of Human Services to submit a report on a quarterly basis to the Senate Committees on Appropriation and Health and Welfare, the House Committees on Appropriations, Healthcare and Human Services, the Joint Fiscal Committee, and the Health Reform Oversight Committee on overall expenditures by program relating to grant JFO 3272. The report shall also include information on any substantial changes to the Rural Health Transformation Program agreement. In addition, on an annual basis, the Secretary shall provide a progress report to the aforementioned committees on the program, including each subrecipient and any available data on program outcomes and other changes or measurable impact to Vermont's healthcare system correlated with the Rural Health Transformation Program. We're going to need a whole separate set of employees to interpret that.
Just to read the motion.
In a second.
Second.
Thank you. Senator Cummings moves, and Senator Perchlik seconds. Any discussion? Please call the roll.
All right. Senator Beck, yes. Senator Cummings,
Yes.
Representative Feltus.
Yes.
Representative Kimball,
Yes.
Senator Lyons,
Yeah.
Senator Perchlik.
Yes.
Representative Shy.
Yes.
Senator Westman,
Yes.
Representative Wood,
Yes.
Representative Kornheiser.
Yes.
10-0-0.
Thank you. And with that, I'm happy to adjourn the meeting. Thank you all.
Thank you
Thank you.
very much. Yay.